When you're told your cholesterol is high, especially in your 60s, 70s, or beyond, it can feel unsettling. Your cholesterol is the problem. Lower it, change your diet, start a medication, watch your numbers carefully. And that sounds reasonable. For decades, we've heard that high cholesterol causes heart attacks. But here's what often gets left out. Cholesterol by itself is not what causes a heart attack. It's part of the picture, but it's not the whole picture. And this becomes even more important as we get older, because heart disease in seniors is usually the result of processes that have been building quietly for years. I'm Dr. Monica Altman, and on this channel, we focus on evidence-based strategies that address the root causes of chronic disease in ways that are practical, realistic, and especially relevant as we age. So let's walk through this carefully. First, how does a heart attack actually happen? Most people imagine cholesterol building up inside arteries like rust inside an old pipe, slowly narrowing the space until blood can't get through. But that's not typically what causes a sudden heart attack. A heart attack usually happens when a plaque inside the artery becomes unstable, ruptures, and suddenly forms a clot that blocks blood flow to the heart muscle. The key word there is unstable. So the better question isn't just, how high is your cholesterol? The better question is, why did plaque form in the first place? And what makes it unstable and dangerous? To answer that, we need to talk about the artery wall. Your arteries are lined with a very thin, delicate layer of cells called the endothelium. Think of it as a protective inner lining that keeps blood flowing smoothly. When it's healthy, cholesterol particles can circulate without causing trouble. But over time, especially with high blood pressure, elevated blood sugar, smoking, chronic stress, or inflammation, that lining can become irritated or damaged. And that's where the process begins. When the artery wall is injured, LDL particles, particularly those carrying a protein called ApoB, can slip beneath the surface and get trapped. Now, this is important. LDL itself is not automatically dangerous, but when it becomes trapped in a damaged artery wall, it can become oxidized. And oxidized LDL is what triggers inflammation. Your immune system responds. White blood cells move into the artery wall. Over time, foam cells develop and plaque begins to grow. So cholesterol didn't start the problem, the damage did. Now let's talk about something that becomes more relevant as we age, particle number. When you look at your cholesterol panel, you usually see LDL cholesterol. But LDL cholesterol measures how much cholesterol is inside particles, not how many particles are circulating. What often matters more is the number of ApoB-containing particles. Each one of these particles has the potential to enter a damaged artery wall. The more particles you have, the more opportunities there are for plaque to develop. Two people can have the same LDL cholesterol number, but very different particle counts and very different risk levels. This is why some people with normal cholesterol still develop heart disease, while others with higher cholesterol may not. As we get older, understanding this distinction becomes especially important. Next, we need to talk about inflammation. You can have plaque in your arteries for years, even decades, without symptoms. Many seniors do. What turns stable plaque into a heart attack is inflammation. Inflammation weakens the outer covering of plaque called the fibrous cap. If that cap ruptures, a clot forms, and that clot is what blocks blood flow. So what drives inflammation in older adults? Excess abdominal fat, poor blood sugar control, chronic stress, lack of regular movement, poor sleep, smoking, highly processed foods, uncontrolled blood pressure. Heart disease is often less about cholesterol alone and more about long-term metabolic stress combined with inflammation. Now let's discuss insulin resistance. Even in your 60s or 70s, insulin resistance can quietly drive cardiovascular risk. When insulin levels stay elevated over time, several things happen. Your liver produces more atherogenic particles. Blood vessels become more inflamed. Nitric oxide, which helps arteries relax, decreases. Arteries become stiffer. This stiffness is something we commonly see as we age, and insulin resistance accelerates it. You might notice higher triglycerides, lower HDL cholesterol, increasing waist size, or creeping blood sugar levels. Sometimes fasting glucose looks normal, but insulin has already been elevated for years. That's why managing blood sugar and insulin is critical for seniors who want to protect their hearts. Another important factor is oxidative stress. Oxidative stress is essentially cellular wear and tear. It increases with smoking, pollution exposure, poorly controlled diabetes, heavy alcohol use, and diets low in antioxidant-rich foods. Oxidative stress is what transforms regular LDL into its more harmful oxidized form, the form that fuels plaque growth. As we age, our natural antioxidant defenses decline, which makes addressing oxidative stress even more important. Now, here's the encouraging part. Even later in life, these drivers are modifiable. Improving metabolic health can stabilize plaque. Reducing inflammation can lower risk. Improving insulin sensitivity can protect the artery wall. Reducing oxidative stress can slow progression. So, what actually lowers heart attack risk in seniors? First, focus on blood sugar control. Reducing added sugars and refined carbohydrates lowers insulin levels and decreases inflammation. Increasing fiber from vegetables, legumes, and whole foods helps improve cholesterol metabolism and supports gut health. Second, prioritize movement. Regular physical activity, even brisk walking 30 minutes a day, improves endothelial function and reduces inflammation. Resistance training is especially powerful for seniors. Maintaining muscle mass improves insulin sensitivity, balance, strength, and overall metabolic stability. Third, manage blood pressure in a comprehensive way. Yes, medication may be necessary for some, but blood pressure is also influenced by insulin resistance, inflammation, stress levels, sleep quality, and physical conditioning. Fourth, prioritize sleep. Poor sleep raises blood pressure, increases inflammation, and worsens insulin resistance. Aim for consistent, restorative sleep whenever possible. And of course, if you smoke, quitting remains one of the most powerful interventions at any age. Now, let me briefly address medication. For seniors who have already had a heart attack, stroke, diabetes, or significant plaque buildup, cholesterol-lowering medications absolutely reduce risk. They save lives in the right context. But medication works best when it's combined with metabolic improvement, not used as a replacement for it. This conversation isn't about rejecting treatment. It's about understanding the full picture so you can make informed decisions. Here's what I want you to take away. Cholesterol is not the sole villain. Heart attacks usually happen when aging arteries are exposed to years of endothelial damage, inflammation, insulin resistance, oxidative stress, and metabolic strain. It's the environment inside the artery that determines risk. And even in your later years, improving that environment can meaningfully lower your risk. It's never too late to stabilize plaque. It's never too late to improve insulin sensitivity. It's never too late to strengthen your vascular health. Small, consistent changes can make a significant difference over time. Instead of focusing only on one lab number, look at the broader picture of your metabolic and vascular health. Ask deeper questions. Work with your physician. Address the drivers behind the numbers. I'm Dr. Monica Altman, and in the next video, I'll walk you through which cholesterol markers matter most as we age, and which ones may not be as important as you've been told. Stay healthy, stay active, and take good care of your heart.